Good morning, everybody. Welcome to the Ophthalmology workshop. My name's Jane Connolly. I'm from the Australian College of Rural and Remote Medicine because I'm in orange. This session will run for 90 minutes, so it covers basically two equivalent sessions on the programme. Once this session is finished, you can actually rate and review the session on the app. So we would appreciate some feedback as to how you found it. A couple of housekeeping notes. If the emergency alarm sounds, please make your way to the nearest exit and don't use the lifts. You'll be directed to the assembly point, and also the toilets on this floor are down on the left-hand side as you go out of the door. Please make sure your phones are on silent. The conference photographer may appear during the session, so if you don't want your photograph taken, you'll need to let that person know. And we are also recording this session, so Akram will make a video recording of this available for you to view in your own time. So also just bear that in mind. When we get to questions, we will be going round with a microphone to take the questions. Okay, so now I'll just hand over to our presenters. So we have three Ransco ophthalmologists who have come from Royal Darwin Hospital today, so we're very appreciative of your time. So we have Susith, Hema and Eline. I hope I pronounced that correctly. And Eline, I think you're up first. Thank you.
All right, good morning. So I'll be doing the first talk out of the three talks, and then we'll be taking a question and answer session at the end of the third talk before the practical session. So I'll be talk about eye history examination and a little bit about cataracts in the end. So I'll start off with the anatomy of the eye, which can be a bit confusing. Just to sort of refresh everyone's memory. So when you look at the eye, you've got this bit here is the cornea, pupil in the middle, the iris behind, and this ring here is the limbus. So that essentially marks the border between the cornea, so where the cornea ends and where the sclera and the conjunctiva starts. If you look at this cross-section of the eye here, again you can see the limbus is around this area here. And the sclera here, the conjunctiva sits on top of the sclera, and the cornea is the clear bit at the front. The anterior chamber is the bit behind the cornea and in front of the iris. And then you have the lens behind the pupil, the sonules here, and then the whole posterior part of the eye, which essentially makes up 90% of the eye, is filled with vitreous. We've got the retina, which is sort of the wallpaper inside the eyeball, the choroid, which is blood supply behind, and then the sclera as a sort of envelope around everything. Now, in terms of the ophthalmic workup, start off like any other problem in medicine. Start with a good history, then a general examination, visual acuity testing. Always do visual acuity for an eye case, and then you move on to other examinations. Slit lamp examination if you have access to a slit lamp, pupils, extraocular movements, and direct ophthalmoscopy if that is indicated. Further ancillary testing if you have access to that, including scans and blood tests, and formal visual testing if that's available. Now, in terms of an ocular history, so again, starting off with the presenting complaint and history of presenting complaint, and this is sort of where the main bulk of your diagnostic clues will come from. Always ask the patient if they've actually had change to their vision. So the patient might be coming in with a red, painful eye, and they're sensitive to light, and they're very miserable, but they might actually still have perfectly normal vision. So that's a very important sort of clue whether there's vision loss or not. Do they have other visual symptoms? Do they have diplopia? And if they have diplopia, always check if it's diplopia with both eyes open or if it's diplopia with one eye open. Because if it's monocular diplopia, it's usually a problem within that eye itself, such as the cataract, trauma, a macular hole. But if it's two eyes, then it tends to be neurological. Duration, onset and progression is also very important. If a patient comes in with vision loss, but that actually happened 12 months ago, then it becomes less urgent to send the patient into a major centre. So always try and sort of pick the patient's brain about that. Ocular history, do they wear glasses? Do they wear glasses for distance or near? Have they ever had trauma, laser injections or surgery? This becomes quite important, in particular in diabetic patients who come in with visual loss. So if you have a diabetic patient who has never ever had an eye check and never had any treatment, and they come in with acute vision loss, then it's more likely to be something like a big vitreous hemorrhage or something like that. But if they've had a history of extensive laser treatment to both eyes, then that becomes less likely. In terms of past medical history in eye patients, diabetes and hypertension is very common. Other things that we always ask about is autoimmune disease, because a lot of autoimmune disorders causes systemic inflammation and can also cause huge problems in the eyes. Steroids, steroid treatments for anything, whether it's tablets, steroid cream, inhalers, can cause cataracts, can cause high pressure in the eye if they've been on steroid drops. So always check for that. And also if they've been recently unwell, been in hospital for any reason, had indwelling catheters, that sort of thing can also cause systemic infections going to the eye. Some eye conditions do tend to run in families. Glaucoma is one of them. There's certain retinal dystrophies, and also things like glasses and squints tend to run in families. In terms of social history for the patient, always check their driving status. Do they still drive a car? Should they be driving a car? And also their occupation and whether they live alone or have any support around the house. Now, there are some red flag sort of questions or issues to always think about with these patients. Flashes, floaters, and visual field defects. If they have those, they could have, it could just be posterior vitreous detachment, which is not a big drama, and 80% of flashes and floaters are just that. But you can't say that without having had the eye examined. So any patient with new onset flashes, floaters, and visual field defects should have an eye assessment pretty soon. Halos around lights, eye pain, nausea, vomiting could mean that they have increased intraocular pressure. So if you have access to an eye care or a tonometer of some sort, that's a really useful ancillary test to do. In elderly patients, any signs or symptoms of giant cell arteritis or temporal arteritis, always be on the alert for GCA in old patients who come in, whether they come in with diplopia or some transient vision loss, etc. And then vision loss, which is transient, and again, GCA could be raised intracranial pressure or amaurosis fugax. And again, just emphasizing the GCA, you sort of have to think about it and send off ESR, CRP, full blood count, for more patients than what you actually need to be able to pick up the ones that actually have GCA. So it's just one of those things where you should be sending off bloods for 8 or 10 patients to pick up one that actually has it, to make sure you catch them. Other causes of acute vision loss include retinal causes such as artery occlusions, vein occlusions, vitreous or macular hemorrhage, detachment or optic nerve ischemia. And if patients complain of distorted vision, so seeing wavy lines, etc., that could mean that they have macular disease, whether it's macular degeneration or an epiretinal membrane. Now, moving on to the eye examination, always test and record vision. It's sort of the number one thing to do, always check vision. So use the Snellen chart at 6 meters. If you're in a place where you don't have access to a Snellen chart, or you haven't got a room to measure at 6 meters, or you haven't got a mirror, you can get 3-meter charts to use. There's also apps that you can download if you have a smartphone, and the apps you can use to test the vision from 30 centimeters. And if a patient has normal vision at 30 centimeters with an app, but blurry at distance, it means that it's a refractive error, nothing else. So as long as you can measure their vision in some way to get some sort of visual acuity, that's really important. Check that the patient can actually understand and read the letters as well, because they may be struggling, but it might just be because they actually don't understand the letters. And so if you have, in those cases, use an illiterate E chart and just ask them which way the arms of the E's are pointing. Always test each eye separately. Very, very important. Patients can be 6'6" and be blind in one eye if you check with both eyes open. Always test them with their distance glasses, not their reading glasses. And again, it's important to specify this for the patient, because if you just tell them to put their glasses on, they might only have reading glasses and they can't see anything on your chart. So just clarify that with the patient as well. If the patient has forgotten their glasses, they don't have them with them, or their visual acuity is not that good, say it's 618 or 612, and you're not sort of quite happy with it, always use a pinhole to correct for any refractive errors. And if you don't have a pinhole, you can make your own. You just get a little piece of cardboard and you stick a pen through the middle, and that's your pinhole. So always do that if the vision is sort of 6/9 or worse. Now, in terms of recording vision, so the numerator is the test distance that you use, and the denominator is the line read. So when you document vision, it's 6 over or 6 on. So a patient who is 6 on 18, it means that the patient can, from 6 meters, read what a person with normal vision can see from 18 meters. And also, if you have a patient and they just can't see the chart for you, I can't see anything, don't sort of give up and say, oh, they can't see anything, they're blind. Try and get an assessment of exactly how bad their vision is. So obviously 6'6" is perfect, 6 on 60 if they can read the top letter. If they can't see the top letter, move the patient closer to the chart or the chart closer to the patient. So if you have a patient 2 meters away from the 6 meter chart, that's 2 on 60 if they can then see the top letter. If they can't see the chart at all, you can get them to count your fingers, and you just document if that's at 3 meters, 1 meter, half a meter. If they can't count your fingers, see if they can see your hand moving, and if they can see the direction of your hand. And then if they can't see that, light perception, can they see light in all quadrants or just in one area? Again, this gives an indication whether, say, if there's a big hemorrhage in the eye, is the retina flat underneath, or is this a big retinal detachment so they can only see? Because the light should be able to go through blood, but it won't go through a retina that's fallen off. And then no light perception means that the eye is essentially blind. Now, pupil examination. So this becomes important if you have an abnormal visual acuity and you just can't find an obvious cause for it. When you check the pupils, use a good strong light. In a sort of darkish room, do direct and consensual, and check for the afferent pupillary defect. So just to sort of quickly go through this, normal pupils, if you shine a light on the right eye, both pupils will constrict equally. If you have a left RAPD, you shine a light on the right pupil, both pupils constrict, but when you swing the torch across to the left, both pupils will dilate. Now, there's a few sort of causes to keep in mind with abnormal pupils. An RAPD just means that the input in that eye is very poor, and it's usually because the optic nerve is sick, but it can also be because of a large retinal insult. So an artery occlusion to the eye or a large total chronic detachment can also cause an RAPD. If you have a unilateral dilated pupil, always sort of think of third nerve palsy, do a thorough eye movement examination, and check the eyelids. And then you have all the other causes of pupils, which includes drugs, trauma, angle closure, glaucoma, and uveitis. So the pupil on this picture is a uveitic pupil, so you can see how it's misshapen. These little things here are called posterior synechia, and it's actually, the iris is essentially glued down to the front part of the lens from inflammation. So this pupil wouldn't be moving much at all because it's stuck onto the lens. Confrontation visual fields, it's quite quick and easy. The main sort of take-home point for that is to keep in mind that when you're doing this, you're actually using your own visual fields as the sort of comparison. So you're presuming that your own visual fields are normal. You always want to make sure that your head and the patient's head is at the same level, and that your hand, when you do it, is midway between the patient's face and your face, or else it's not fair. You know, if you keep the fingers closer to the patient or closer to you, you'll see different things in terms of your fields. And always think in quadrants when you document the visual field. Now, moving on to the slit lamp exam. If you have access to a slit lamp, make sure that the patient is comfortable. That's the number one thing. If you have a patient who is sitting on the slit lamp, but the slit lamp is too high and their head is sort of falling off the chin rest, you're not going to be able to see anything because the patient won't stay still and you won't be able to focus. So make sure that the table is the right height, that the patient's eye is at line with the black line on the slit lamp, and that the patient is comfortable and steady. And also make sure that you're comfortable. The tetrakin tests, essentially, if you have a patient who comes in and they've got a really painful eye and they can't open their eyes and it's watery and they're just, they're really in distress, there's no harm putting some tetracaine or methicaine in the eye to see if that settles them. So put a few drops in, wait a minute, and see if that improves the problem. If it does, it's more likely going to be a corneal problem, like an abrasion, a foreign body, keratitis, something like that. If you have a patient with acute angle closure glaucoma who have exactly the same symptoms, the tetracaine is not going to do anything because the pain is not coming from a defect on the cornea, it's coming from the high pressure inside. So it's a very useful sort of initial test to just get the patient comfortable if it's a corneal problem, and also you'll be able to examine them after that. Now, the slit lamp is a good machine. You can essentially, even without the slit lamp lenses, you can look at anything from the lids through the cornea, the anterior segments, all the way to the anterior vitreous. Most commonly, there'll be a problem with the cornea that you can pick up with the slit lamp. So always make sure you have a good look. Don't have the magnification too high. Have it fairly low so that you can see the whole cornea. And you sort of want to scan across it and make sure you've looked at everything from top to bottom, right and left. And make sure that you identify any foreign bodies, any white patches, which usually is infiltrates or scars. Do a fluorescein test. Make sure you find the blue light on the slit lamp. It can often be a bit hard to find on some slit lamps, and so people use the green light, which won't give you the desired effect, essentially. But you want to use the blue light on the slit lamp. And look into the anterior chamber. So put the beam on the side and look into the anterior chamber. Is there a fluid level in the anterior chamber? So if there's any fluid at all sitting between the cornea, covering the iris, that's an ocular emergency, essentially, if there's blood or pus inside the eye. And you also want to check the intraocular pressure if possible. You can do that with the slit lamp, with the Goldmans, if you know how to do it and you've got practice. The tonometers are really good as well, and they're really easy to use, and it gives really invaluable information. If you haven't got any of those, but you're worried about an acute angle closure glaucoma, you can also do palpation of the eyeballs. You essentially put your thumbs on top of each eyeball and you just feel, and if one feels rock hard and the other one feels sort of nice and soft, then you know that the pressure is high in that eye. So these are just some pictures. So on your right-hand side, you've got a cornea with a big white patch in the middle. So this is an infected keratitis. And if you look quite closely, and again, look at the whole cornea, look at the whole anterior chamber, there's a little level there of white stuff. So that's a hypopion. So that means that there's significant inflammation inside the eye, so much that there's actually a level of pus sitting at the bottom of the anterior chamber. So this, on your left-hand side, is this is again fluorescein test. There's a big corneal defect there. This is someone who's had an alkali burn. So you can see there's a little bit of sort of subtle staining around the edge here on the conjunctiva as well. Now, this one to the right again. So that's blood in the anterior chamber. So you can see how the blood doesn't go outside of the limbus. It's held in place by the cornea, and it's covering the iris. So hyphema is a very different thing to, a subconjunctival hemorrhage, which would never go across the cornea. So subconjunctival hemorrhage is always covering the sclera. It's under the conjunctiva, but it doesn't go into the AC or doesn't cover the pupil at all. And then on the left-hand side, you have a hypopion, which again is pus in the AC, and you can see clearly what the cause is in this case as well. They've got an infected keratitis at the top of the cornea there. Now, okay, sure. Okay, I'll go a bit quicker through the rest. So direct ophthalmoscopy can be quite tricky, particularly if you don't get a lot of sort of chance to practice it. Even if you're very good at it, it's only good for the posterior pole, so it's good to check the nerve and the macula, but it doesn't give you a wide view of the fundus. It is easier with the dilated pupil, so don't be afraid to use tropicamide. And even if you can only get the red reflex, that can be a useful thing as well. If you have a red reflex in one eye and not in the other, that's a useful piece of information. But don't despair too much, because even if the posterior pole looks normal, but if the history suggests something serious, they will still have to be seen by an ophthalmologist. So taking a good history is more important than being really good at ophthalmoscopy. And just to remind you that no child is too young for an eye exam. Check the red reflex, and any squints need to be referred on. Now moving on to cataracts very quickly. So it's essentially responsible for half of the world's blindness, about 20 million people. And we're lucky in Australia that we have good access to surgical management. But even in Australia, it's in the top 5 leading causes of blindness and vision impairment. And blindness rates in Indigenous people in Australia is 3 times higher than that of other Australians. So this is the lens here. And it's held in place by sonules. They're sort of suspended from the edge here. This is just a diagram of the lens. So the way that the lens grows, essentially, the lens continues to produce lens fibers throughout life, and the fibers grow inwards, and then you have new fibers packed on top of the old ones. So the lens just gets thicker and thicker and thicker and denser as you move through life. It also starts to go a bit yellow because of the density of the lens fibers. And that yellow hue is the sort of common nuclear sclerosis cataract. So nuclear sclerosis just means lens going yellow with age, and this is sort of the difference you might expect to see before cataract surgery and after cataract surgery. Other things that happen, so it increases in size, decreases in flexibility, and you get opacities forming with cataract. You also get what's called a myopic shift with cataract. So as the lens gets thicker, the light refracts further away from the retina, and so the patient might just need new glasses if the cataract is still quite early. Now, the cataract essentially is derived from the Latin cataracta, meaning waterfall. Due to this appearance, that looks like a mature cataract. It's essentially, with age, the lens proteins denature and degrade over time. There's also other things, other environmental factors, diseases, particularly diabetes, that can sort of speed up that process. So people with diabetes, for example, they tend to get cataracts at a younger age than someone without diabetes. Now, so aging is the #1 risk factor, but like we said, there's other ones too. Ocular trauma can give you an instant cataract. Uveitis will give you cataract. And again, steroids we talked about before. So drops, tablets, creams, inhalers can all give you cataracts. And there's a whole long list of other causes, including congenital infections, skin diseases, and different genetic symptoms and metabolic disorders as well. So this just shows the nuclear cataracts are in the middle. The cortical are sort of in the cortex around here, and the subcapsular sit just underneath the capsule of the lens. And this is what a typical nuclear cataract looks like. Essentially, the visual symptoms that people get is just a gradual defocus, dimmer images, and dimmer colors over time. Often, with nuclear cataracts as well, people may not know that they have them, and just because they have a cataract, if they're not troubled by the symptoms, surgery can wait. With cortical and subcapsular cataracts, so you can see how the cortical spokes are sticking through here. They tend to get slightly different symptoms, often more glare symptoms, reduced contrast. And they, particularly the subcapsular cataracts, tend to progress much quicker as well. Treatment, the only way today to treat a cataract, to remove it, with surgery. And surgery has been around for a long, long time, since about 500 BC. The first type of cataract surgery was called coaching. And essentially, they stuck something sharp into the eyeball and just dislocated the lens back into the vitreous to get it out of the way. But it was sort of variable success. And they didn't have anything else like a new lens to put into the eye, so This is just some other pictures about, you can see here, the white cataract here, and they're sticking something sharp in there and pushing it into the vitreous, and then they're left with no lens there. This technique is still being used in some places of the world, and obviously it's got a very high infection rate and a very poor outcome in a lot of cases. So this is someone who's had couching who's ended up with a nasty infection and gone blind in the eye, essentially. Things got better as we went through the 18th and 19th and 20th centuries, and in 1940 the intraocular lens was developed, which is this one here. And that's what we do today. So you have a range of different types of cataract surgery, and for pretty much all of them you put the lens into the eye so that people don't have to wear really, really thick glasses afterwards. This is called manual small incision cataract surgery, and this is a technique that is really useful in low-resource settings where you can't afford the really expensive phacoemulsification machines and equipment. To do this, you need essentially a microscope and some equipment, but it's a very good operation and has very good outcomes as well. So it's just a scleral incision here. The incision is narrower on the outside and wider on the inside, and you push the whole lens out basically and put a new lens into the bag again. And this is phacoemulsification. So you've got the tip here, an ultrasound tip. You crack the lens in a few pieces and suck it out, and then again put the lens into the bag of the eye. And this is just if you see a patient and they've had surgery, this is what they might look like on the slit lamp before cataract surgery, and this is what they might look like afterwards. So you sort of get this clear, transparent lens with the slit lamp beam. And that's the end.
Hello everyone, I'm Hema Karthik, one of the ophthalmologists based at the hospital here. I would like to thank ACRIM for the opportunity to present today. And I am going to talk about ocular emergencies within the spectrum of trauma. So again, the first thing to do with any emergency eye presentation would be examination, which Eline has gone through quite well. With the trauma, with the presentation of trauma, what we would look for quickly to rule out all the nasties straight away would be, is there an obvious globe rupture? Is there a penetrating eye injury? Is there uveal tissue or iris prolapsing out of the front of the eye? Is the globe pushed forward, or is it kind of looking sunken, because they can mean different things? Are the extraocular movements restricted? Is there a suggestion of an intraocular foreign body from history or from examination? And is there a blood level or a hyphema like we saw before? So I would just quickly go through corneal foreign body because it is a type of trauma. It is something that we all see on a day-to-day basis as general practitioners, as ophthalmologists. The first slide on the top on the left basically is to reinforce the fact that any suggestion of foreign body, the exam is not complete until the eyelid has been everted, because most of the time that's where the foreign body would lodge. If the middle picture again, if you see those kind of linear aberrations with fluorescein, you don't need a slit lamp. Sometimes just magnified blue light with a bit of magnification can make that evident. Again, that's a telltale sign to say that there is a foreign body under the lid. The more peripheral the foreign body, the luckier the patient. The more central, we will need to warn the patient that he or she might end up with scarring, a bit of glare, which with time might improve. The things to be wary of when we deal with foreign bodies are the depth of the foreign body, because unless you have a slit lamp, a deeper foreign body, attempted removal further deeper can almost lead to a penetrating injury through the cornea and any sign of infection. So a corneal erosion, just the difference between a corneal erosion and a corneal infiltrate, they're two different things, as Eline put up. A corneal erosion is a very common presentation after trauma. It's a day-to-day, with day-to-day affairs, you can see it. Commonly, fingernail injury, little children reaching up to parents and scratching them with their soft fingernails, palm frond injuries, any type of burn, chemical or thermal, extremely painful. So pain from a corneal abrasion, which is basically loss of the top layer of epithelium from the cornea. The pain cannot be a differentiating factor between an erosion and an infection. So, all of these are quite painful because the cornea is a very sensitive part of the eye. They heal really well. Closing ointment or antibiotic ointment to sterilize the cornea till it heals is good, usually 24 to 48 hours. So the picture there, basically an erosion or an abrasion, the cornea is still clear before you put the fluorescein on. So the top layer, the top picture has an abrasion, which I've marked out in the middle. So you can just see the outline there, but it's still quite clear cornea. And when you put the fluorescein, it will light up. So this is a different eye though, but it will light up like that. And you wouldn't need, sometimes if you don't have access to a slit lamp, still an abrasion will make itself quite evident with fluorescein. Now, when we treat abrasions, we would need to watch out for infection. So when you get an infection, you start to see white on the cornea. So any white on the cornea which takes up stain, so if both criteria are met, then that means it is usually a bad infection. Just to reinforce again, so this is not an abrasion that led to an infiltrate, this picture. It is a contact lens wearer who came into clinic. So this is day 2 of her symptoms, and that's day 3. So within 24 hours, an infection in the cornea, this is Pseudomonas infection, can literally eat away the cornea. So the slightest hint of white means that this patient might need specialist care or at least a specialist opinion. Hyphema is basically blood in the chamber, anterior chamber from the iris. The source is the iris, and any kind of trauma can cause it, but most commonly it's blunt trauma. So it can be squash ball injury, punch to the eye, any of those. The principles in managing a hyphema, one is we want to get rid of the blood, so slowly with steroid drops that it's like a bruise, so it will reabsorb. The hyphema, by the blood in the anterior chamber, can cause the pressure to go up, so we need to monitor the pressure and treat it if it's high. But the main principle in treating a hyphema is to prevent a rebleed, so because the rebleed is usually much worse and nastier than the primary bleed itself. So strict bed rest and so if they're kids, we literally admit into hospital and say strict bed rest with toilet privileges, and it is pretty much the same for an adult. So we kind of explain to them that if you were a kid, we will be putting you into hospital, just to make sure that they take it very easy for the first 7 days or so. Lid lacerations can be simple to really complex lacerations. As with any laceration anywhere in the body, the first thing to do is to irrigate and to re-examine and assess the extent of the laceration, because they can be quite misleading at the beginning. So the top picture is actually just a superficial laceration, but I have seen lacerations that look like that, but then when you prod with a cotton bud or a clean instrument, they can literally go through and through. So, and I have known of a case where a patient with a similar looking laceration was discharged from hospital from emergency, and 5 days later developed a total retinal detachment and lost vision because the penetrating injury had actually gone all the way through the lid and into the globe and caused a retinal tear, which was not picked up at that time. So always important in any kind of superficial appearing laceration to still examine the eye. That can't stress that even stronger. So complex. The reason why lid lacerations are a bit more complex to manage is because the lid is special skin. It has a special function of protecting the eye, because if a patient has a compromised function or anatomy of the lid, then the eye is doomed. So it has a very important function of protecting the eye, and it also has complex anatomy. It has an anterior lamella, posterior lamella. It's got cartilage. It's got the tear duct on one side. So the anatomy needs to be preserved and the function needs to be preserved. Things to watch for when we see a lid laceration is that margin involved. So in this patient, yes, there's multiple layers of cuts through the lid margin. This is a car accident. Also to watch if the canthus, so that's the medial canthus and the lateral canthus may be involved, but more important is the medial canthus, because that's where you have your lacrimal apparatus. So we just need to be aware that this patient might end up with tear duct problems. Dog bite injuries, usually in children, end up with lacerations in that medial canthal area. Simple lacerations can be repaired. If you have a pair of loops, they make it much easier. We use 6 of Vicryl or that size sutures, and we remove the sutures in 5 days. But again, examine the eye is very important with any of them. Blunt trauma forms a majority of eye presentations from trauma, and they can cause, it's a force injury, and it can cause layers of damage to multiple layers in the eye, as you can see here. The most common injury from a blunt trauma is a facial fracture, and this is actually this was published by our Max Fax colleagues from the hospital, and unfortunately in the Northern Territory we share the non-prestigious second place of facial fractures in the world, second next to Greenland, and alcohol consumption is a major contributing factor to that. It's a proven thing. So orbital wall fracture happens when the size of the object that causes the injury is larger than the diameter of the anterior part of the orbit, and it's a force that is transmitted across the orbital wall. The most common wall to give way is the inferior orbit, so it decompresses into the maxillary sinus, or the medial orbit because the wall is quite thin. Now, the fracture by itself is actually nature's way of decompressing the orbit to protect the eyeball, because as we all know, the orbital structure is like a cone, with the posterior part being quite narrow, and towards the posterior apex of the orbit we have the vital optic nerve passing, all the tendons kind of end up there, so it is quite a compressed closed zone, which if has bleeding or anything that's space occupying that occupies space in that zone can compress the optic nerve. So again, here we see a lot of punches and kicks to the eye, unfortunately. So with imaging, you can see that this patient has a right inferior orbital wall fracture with prolapsing of the muscle. Sometimes the muscle can get entrapped in the fracture site, which then can present like quite a hemodynamically unstable patient, because each time the patient tries to look up, it will trigger a vasovagal syncope. Also, if there is bleeding into the intracorneal space in the orbit, it can become an urgent compartment syndrome of the orbit. So it is quite a serious thing to watch and manage. So the principles, if you suspect somebody to have an orbital fracture, the first thing to do is to examine without delay, because the swelling just exponentially increases with time, because the eyelid is loose skin, so it just swells up quite quickly. We see multiple times, we see patients that come 6 hours, 3 hours after the injury, and they literally are so swollen that there is no way you can even have a decent look at the eyeball. So examine as soon as you can, document the vision at 3 meters or 6 meters, whichever is available, and a quick check of the pupils and extraocular movement. So basically, if we do that, then we know that at least there's no globe rupture, maybe there is a hyphema, things that need to be managed urgently can be picked up quickly. Retroorbital hemorrhage is one of the consequences of a blunt trauma and an orbital fracture. So managing retroorbital hemorrhage is probably the heart of my talk, because it can be a vision-threatening condition, and we can do things that can save vision with quite simple procedures. So when somebody has a retroorbital hemorrhage, the way they present would be quite tight eye, very restricted movements. If the optic nerve is already starting to be compressed, the pupil will not react well, the vision will be quite compromised, and the pressure will be high. So if there is access to imaging, we will be able to see quite anteriorly displaced orbit, proptosis, and lots of stranding in the intracorneal space. So this is one of our patients. It's about 5-6 years ago. So he came in from a community after he was punched and assaulted in the face. We saw him 6 hours later. The registrar saw him around midnight. So when you first look at him, the thing that catches attention is the pink tissue from the left eye, but that's just a bad laceration with the conjunctiva showing. Closer look will show that right eye is quite swollen, quite tight. I don't know if it projects well, but that's the cornea. So it's all just very tight. He at around midnight that night, 6 hours later, he was no perception of vision in that eye, with very high pressure, poorly reacting pupil. The left eye was 6/24 vision with lid lacerations and reasonable AC. So, at that stage, we knew that this patient just needed care for the right eye, and urgent imaging, because we had access to it, showed that, again, he was proptosed and he had a big retroorbital hematoma there. So as we know, we've spoken about the signs. Again, this is another patient. Now, if the proptosis is difficult, because lid swelling can be different to proptosis, so it's ideal to, this picture doesn't show it, but we're looking for the apex of the cornea, how forward it's pushed, not really the lids, because the lid, pushing forward of the lid is basically from swelling. So sometimes looking at the patient from the top or leaning back and looking at them from the chin can give you that orientation of how far the globe is displaced. That's another image with a large hematoma behind the left orbit. So this sight-threatening condition can the damage from it can sometimes be limited or almost nullified by a very simple procedure called lateral canthotomy or cantholysis. The whole diagnosis of retroorbital hemorrhage is a clinical diagnosis, so there is no excuse of waiting to treat a presumed retroorbital hemorrhage because we don't have access to scans or because we haven't had a chance to examine the patient. So this condition should have very low threshold to diagnose or suspect, and you should have a very low threshold to treat. So we never get into trouble, or we never will be questioned if we did a lateral canthotomy cantholysis on somebody who retrospectively did not need it, but the other way works as well. So if somebody had a suspicion of retroorbital hemorrhage with a tight orbit and a canthotomy cantholysis was delayed, that patient could lose vision. So that is the take-home message from this. So it is a simple procedure. What we aim to do, so canthotomy is basically cutting through the lateral canthus, and cantholysis is cutting through the inferior crus of the lateral canthal tendon. So it would help if you could clamp the lateral canthus with an artery clamp for a minute, because that will avoid much more nasty bleeding. So cut through the lateral canthus. There are a couple of videos to go through it, but we cut through the lateral canthus. So that cut's been made, and then you pull the lid down and out. And you have to, it's almost like strumming a guitar. You strum the the inferior crus of the tendon, and then you cut that. So once you've done that, you can see that that lid just falls loose and gives enough space for the globe to decompress further and releases the tension around the nerve. So that's the first video. So a bit of local anesthetic definitely, and artery clamp if you can. So that's the canthotomy. So I just paused. So the principle again with this is to keep the sharp end of your instruments away from the eye, and then there's literally not much to damage. So apex of this, the sharp tip of the scissors or your needle, all of them pointing away from the eye, and you're in safe zone. So I'll just get that video going again. So canthotomy being done. And then you pull the lid down and strum that inferior crus of the tendon, so you will feel, quite tight, like cartilagey feel. So once you feel that, you have to do multiple passes to make sure that you've got all of it. And once that's done, you can see how that lower lid just drops freely. So that's the sign to watch out to make sure that, yes, the whole cantholysis is complete. So in real life, if any of you were in a situation where you needed to do a canthotomy cantholysis, you wouldn't have a patient that looks like that, not swollen white eye. It would be more like this, so you can see that this patient, much more swollen orbit. You can tell that, there is some proptosis there. So it is much more messier, so a lot of bleeding. And sometimes the whole process is more by feel rather than by vision, because it just pours out blood. But has to be done, and we go ahead and do it. So it's just showing the principle again. So that's the superior and inferior crus, and we cut the inferior crus there. You can see how it's much more, there's lots more bleeding in usual emergency situations. And that's that. So again, if at the end of today's talk, and be more than happy to answer more questions about it, but at the end of today, if you would go home confident that if you had a patient that needs a lateral canthotomy cantholysis or will be delayed by a few hours before he gets access to it, and you think, yes, I can do this, then I think I've achieved what I set out to achieve today with this talk. So that's the heart of it. Penetrating eye injury and rupture globe, it is a sight-threatening injury again, so sometimes it is quite nasty, like this is one of our patients, where you will obviously see lots of iris tissue and uveal tissue prolapse. Sometimes it is not as obvious because the rupture could be posterior, in which case you don't see the rupture. The eyeball will, however, appear, even though there's a lot of swelling, as in this eye, but it's a soft eyeball. It's not a formed because it's lost its integrity, so it's a deflated eyeball. In smaller injuries, smaller ruptures of this penetrating injury, you would see a little bit of iris peeking out, and that gives you that teardrop or peaked pupil sign. So a peaked pupil is a sign of a penetrating injury somewhere in the anterior part of the eye. Again, if you have access to imaging, you can see that the integrity is lost in that eye. So this is one of our patients who was punched to the eye and had a very bad rupture globe. So this is only part of it. She went on to have a posterior, about 180 degrees of rupture globe and lost vision. There's not much that can be done to a penetrating eye injury or rupture globe until the patient is on the theater table, anesthetized. So basically it's first aid until that spot. Even when we see the patients, the principle is to stop examining and cover the eye, because every attempt at examining and the patient moving the eye will push more intraocular contents out of the eye. So we stop examining, protect the eye. So if you have a shield, a proper shield, that's good. Otherwise, the styrofoam cup just kind of cut in half works still the same, and just theater protocol, fasting, tetanus, and all of that. IV antibiotics to cover. We sometimes use oral Cipro because it has good penetration to the vitreous. Chemical eye injury. Again, it can happen with any kind of chemical exposure. Alkali is worse than acid, so oven cleaners, bathroom cleaners, all of that are common things that can cause chemical injury to the eye. Basically, they attack they cause a long permanent effect on the limbal stem cells, so they can cause limbal stem cell failure, which can have tremendous destructive potential to healing of the eye and vision in the eye as well. So with chemical injury, so if there's any hint or any suggestion that there would have been a chemical insult to an eye, again, the principle is to stop history taking, stop examining, just start irrigation, because the earlier we restore the pH to physiological pH, which is about 7.3 to 7.5, the better for the eye. So you irrigate is the principle of treatment. And after a bit of irrigation, then checking pH, and if the pH is not coming down quicker or getting back to normal quicker, then you evert the lids, make sure that there's nothing under the lids, like particles that could cause ongoing insult of chemical injury. Then the irrigation, until you remove these particles, the irrigation is not going to be as effective as you'd want it to be. So pH can be checked. There is a universal pH indicator, which is much more gentler because it's a softer paper. But if that's not available, both of these, the eye needs to be anesthetized before you use it. Urine dipstick works the same as well. And irrigation can be done with just plain IV fluid with the bottle quite high for pressure, and you hold the lids wide open, get the patient to move the eye in different directions, and you basically want to get the fluid under the eyelids, especially the upper lid, because that's got the deeper phonics. There is the option of the Morgan lens, which has got like a flanged plastic that attached to the end of the IV tubing, and it basically, the advantage is it gets that fluid to irrigate better around the phonices, but also it can cause a bit more corneal irritation, and it's quite uncomfortable for the patient. So just a few examples to highlight what we've gone through today. So this lady, a 90-year-old lady who stumbled from a bed in the nursing home, she was on warfarin. When she presented emergency, there is an obvious brow laceration that can be seen. However, she repeatedly complained that her vision was really blurry in that eye, and the only ocular history we could get was that she'd had cataract surgery from a private surgeon 3-4 years ago, so that was not recent. Anything that you can see in that picture? That's her intraocular lens that is out. So she's had a rupture globe, or the basically lost integrity of the globe, and the lens has plopped out of the eye. So So this is a 51-year-old Vietnamese male who had recently moved to Australia, complaining of poor vision for the past 10 years. Very vague history. The only history he could say was that there was some splash injury at work when he was a builder, and when he eventually made it to the hospital, he was told that it was too late and the damage was already done. So what could this have been? It was a chemical injury, probably alkali injury to the eye. And what could have saved him? Probably prompt irrigation at that time, within hours we're talking. This is a young male who was brought in by the ambulance, could not recall the events in the last 4 hours, so we don't know history, but very poor vision and pain in the left eye, difficult to open the lids, and almost zero ocular movement, so fixed, tight eye. So what would be the first diagnosis that we should think of in this presentation would be a retroorbital hemorrhage, and the next step is, if you have access to image, otherwise lateral so the vision is down, so for him the vision is down, eye is proptotic, and nil ocular movements. I think that is enough to say, yes, this patient needs a cantharomic antholysis. If we have access to measuring pressure, then we measure pressure. That gives us another additional criteria to say we justify to go ahead and do that step. So this is a young lady who came in 2 hours after squash ball injury to the left eye. She could still see quite well and all of that, but in emergency she kept on feeling quite unwell. She was nauseous and just didn't seem right. So the next step would be to do a proper exam. So, anti-segment exam was reasonably normal. However, extraocular movements, you can see that the left eye does not elevate as much as the right. And because it was a blunt injury, we suspect orbital fractures. She went on to have imaging, and she had this inferior orbital wall fracture with herniation of the muscle, and that's the reason why she can't look up. And why was she not feeling that well? Because she was getting an oculocardiac reflex every time we were trying to test her or she was trying to move the eye. Finally, some feel-good pictures. So this eye was from that patient. So he went on, so he was, in ICU when we saw him because of the car accident and other things, but he went on to, when the surgeons fixed other things, we repaired the eyelid. He was fortunate because the rest of the eye exam was completely within normal limits. Once he was out of hospital, he was 6/6 vision and did really well. And this friendly gentleman is our patient who came in with no light perception in the right eye. So he had multiple injuries in both eyes. The registrar performed an emergency lateral cantharomic canthopexy around 1 a.m. in emergency. Then within the next few days, the lid lacerations were fixed. And about few months later, he had subluxed cataracts as well from the injury, so he went on to have cataract extraction and IOL implantation. And 6 months post the cataract surgery, about 1 year since he had the injury, he was seeing 6/6 out of both eyes. So that's like an unexpectedly excellent outcome for him, because we were really worried about the right eye. But the take-home message again for him, for this patient, is the most vital step in his management, especially for the right eye, was that cantharomic antholysis that the registrar did in the middle of the night. I mean, that's what saved the right eye. That's it. Thank you. Any questions? I think you have to go all the way down. Sorry, my bad.
You go to the end.
Yeah, you go to the end and then, sorry, Susith.
It's okay. Good. I can. Okay. Good morning, everyone. Thank you for still being here. And there's some familiar faces. Nice to see you all. So, in the past hour, I think you got a lot of information. And if you are like me, I don't think you can have more information. So, this session will be more hands-on. Like the printout you can find on your table would be the summary and the take-home message of the presentation. So, the talk is about red eye, and there are hundreds of causes of red eye, and there's no time or practicality to go into each and every cause and their details. So the plan would be to work in differential diagnosis when you see a patient walking with red eye to your consultation, and then in the second half of the lecture, we will try to figure out how simple basic eye examination and history can help you to differentiate sinister presentations from more benign ones. I think that's the decision you need to make when you, in a rural situation, when you see a patient walking with a red eye. Okay, so we'll first use this hand-drawn diagram on front of your page. You can work in maybe groups of 2 or 3. I'm sorry if you don't have your own copy. Jane's promised that she could get you copies if you want later, right? But so what I'm asking you to do is take a few minutes to try to write down few causes under each category. To help you out, I start with the first section, inflammation, right? So inflammation, as we know, is a common cause of red eye, right? Any structure getting inflamed can cause redness. And the structures, different structures on the eye have different names we give when it's inflamed. For example, lid margin we call blepharitis, conjunctival inflammation is conjunctivitis. I'll give you about 30 seconds to work in a group or by yourself and try to complete that list if you can write what you call the inflammation. So that's a diagnosis in a way. Okay? Okay, so I got you to think, and that's good. So we'll go through the list. So lid margin is blepharitis, conjunctival inflammation is conjunctivitis, corneal inflammation is not corneitis, it's keratitis, okay? And episclera inflammation, it's a layer between the conjunctiva and the sclera, episclera, it's called episcleritis. Scleral inflammation is scleritis. And the iris, we can call it iritis. Sometimes it's synonymous with anterior uveitis. And the uvea is the area of the eye, like Eline explained, the iris, ciliary body, and the choroid, the whole blood vascular layer of the eye. So uveitis is a generic term, and it can be anterior when the iris is involved, intermediate when the ciliary body is involved, posterior when the choroid is inflamed. And the orbit can have different names. It fits infection, we call it orbital cellulitis, or it can be non-specific orbital inflammation. So these are the structures that can get inflamed and cause a red eye. Okay? But there are further subcategories for each this inflammation. It can be associated with infection or without infection. And for example, conjunctivitis can be secondary to infection, can be from viral, chlamydial, or bacterial, or can be non-infectious conjunctivitis from allergic or toxic causes, and so on. The list can expand. So I'm not going into all the details, but just letting you know that you can work out a differential diagnosis using this format, right? Next is an important cause. I wrote it there, acute angle closure glaucoma or acute angle closure attack. That should be another important cause of red eye in your differential diagnosis. Right? When a patient walks in, it's uncommon, but it's important. So you need to think about it. So that's why I have it there, and it's a angle becoming narrow and the eye pressure going to extremely high levels, cause threatening loss of vision. We will come into more details later. So another cause for red eye is when the blood is, now in the other causes the blood is within the vessels. Sometimes the blood is outside the vessel, and subconjunctival hemorrhage is a good example that can present as a red eye when the blood is outside the vessels. Right? Another form of red eye is when the venous drainage from the eye is compromised by various causes, because the veins from the eye and the front of the eye drain either ophthalmic vein through the orbit into the cavernous sinus, and if there's something compressing the obstructing the venous flow, it can cause dilation of vessels and congestion. So orbital inflammation, thyroid eye disease, carotid cavernous fistula. If there's abnormal communication between the carotid vessels and the cavernous sinus, it can increase the venous pressure and cause a red eye. These are very rare, but has serious consequences if missed. So I think it's important to have in your list of differential diagnoses. Okay. Next, we will move on to the table, which you will find on the other side of that diagram. Okay. So what I have done is I've listed there are different common presentations of red eye, as well as some not so common but important blinding conditions that can present as red eye. And on the left, the blue in blue is the things that clinical features we are going to look for in the history and the basic examination, which you can do in a rural setting. Right? It doesn't have to be ophthalmology clinic. It's to ask without pain or photophobia, about the visual acuity, which Eline explained, and also whether the pupils are reacting to light and dark in a normal way, whether there's fluorescein staining and fluorescein uptake, how are the eye movements, and if you have access to ways of measuring intraocular pressure, what is the intraocular pressure. And there are other more defining features in the history and examination for each condition, which I might not have time to go into, but you can feel that later by looking at each condition in a textbook or somewhere, right? But these features will help us to differentiate the more sinister one from the less sinister ones. Okay, so the first challenge for you is to fill the column for conjunctivitis. Just circle the response, what you think you would expect. So in medicine, there's always exceptions. So we would think of a typical presentation, and this is a non-trauma situation. Okay. Okay, let's check whether my list and your list match. Okay. So in typical conjunctivitis, the patient might complain of irritation and discomfort, but it's typically not with pain. Right? There shouldn't be pain and photophobia. But they might complain eyelids are stuck together in the morning, there's some irritation, but it's not typically painful if it's only conjunctivitis. And the visual acuity should be normal if it's just conjunctivitis. And pupil reaction to light and dark shouldn't be affected in conjunctivitis. Fluorescein staining of the cornea should be normal. Okay? And ocular movements, we don't expect any abnormality in the ocular movements. And the intraocular pressure should be normal. The other features would be, the history would be contact history, usually bilateral, watery or purulent discharge, and yeah, so usually it's self-resolving in a few weeks. Okay, good. The next column, we have a few more minutes to do that. Subconjunctival hemorrhage. This is in the setting of without trauma, because this is spontaneous. Okay, because Okay. So in a spontaneous subconjunctival hemorrhage not associated with trauma, we don't expect any abnormality in those features which we discuss for typical conjunctivitis, right? So subconjunctival hemorrhage can occur spontaneously, sometimes from hypertension or eye rubbing. Often it's associated with trauma, but we are excluding trauma situations because that was discussed in a separate lecture. In a typical subconjunctival hemorrhage, spontaneous onset, it should be as similar to conjunctivitis, but they wouldn't have the watery discharge and the crusting and all that. Okay, good. That was easy, and let's move on to the next situation: infectious keratitis. So keratitis is inflammation of the cornea, and infection, secondary to infection, a corneal ulcer. We'll try to circle the responses. Okay. So in infectious keratitis, usually there is pain and photophobia, and the visual acuity would be reduced because it's involved in the cornea. Okay, and the pupil reactions to the light should be normal. Fluorescein staining of the cornea, what do you expect? Should be abnormal. We have seen some slides before, because it's a defect in the corneal surface. There'll be a fluorescein uptake, so that would be very helpful. In the picture I showed you earlier, it's quite obvious, but sometimes the infectious keratitis is not this obvious. It's sometimes subtle. So fluorescein staining becomes useful in that situation. And the ocular movement shouldn't be affected. Intraocular pressure is expected to be normal. And if you go into other features in the history, there may be a history of trauma, contact lens use, and investigations. If you do a swab or a corneal scrape, you should find evidence of any organisms, right? So that's about corneal ulcers or infectious keratitis. I'll just touch on fluorescein staining. I know it was shown earlier, but you can use the strips or the fluorescein minims to stain the cornea. Okay, and you have to use a cobalt blue light, not the green light, to see the ulcer highlighted. Right? Ulcer will be highlighted in green, and a street lamp would be nice to have, but it's not essential. If you have another source of blue light, you might be able to highlight the ulcer. Okay? So fluorescein staining is an important thing to do in the differential diagnosis of a red eye. Okay, so the next challenge is anterior uveitis or iritis. Okay. So let's see whether the list matches. So again, in anterior uveitis, you would expect some photophobia and perhaps pain. The visual acuity is expected to be reduced, and the pupil reactions, because there's inflammation in the anterior chamber, the pupils may not react normally. They are usually constricted, and you wouldn't expect fluorescein staining of the cornea because the corneal surface is smooth and intact, right? Sometimes there can be combinations of some anterior uveitis in the patient with infectious keratitis. So there are exceptions, as I said, always, but this is kind of the generic common presentation. So ocular movements wouldn't be affected necessarily in anterior uveitis, and the intraocular pressure I put as normal because it can be normal, it can be high, sometimes it can be low, depending on the effects of the inflammation on the ciliary body or the trabecular meshwork. The pressure can vary, and but it can be normal. And if you mark it as abnormal, I wouldn't. I would consider that correct. Okay. So we'll move on to the next condition, acute angle closure attack, and let's see what responses you will get from that. Okay, so let's compare the lists. So in acute angle closure attack, there will be pain and photophobia, and we will expect the visual acuity to be reduced, and the pupil reactions would be abnormal because it's stuck in that sort of semi-dilated situation. Okay, and fluorescein staining, we wouldn't expect any ulceration in that situation, so it will be normal, and ocular movements would be normal. But if you have access to measuring the intraocular pressure, that obviously will be elevated. And more defining features would be, if you have a slit lamp, you would be able to see that the gap between the iris and the peripheral cornea is so small, or that's very close together. So there's angle closure. The angles are very narrow. Okay. So there are other features in the history and examination you can go into, but I think for the time's sake, we will leave it here. And let's fill the next column for orbital cellulitis. Okay, very good. Let's compare the lists. So in orbital cellulitis, we would expect pain. And this column is a bit tricky because orbital cellulitis at early stages, right? The vision can be normal, and the pupil reaction to light can be normal. And the fluorescein staining, there won't be any fluorescein staining. Ocular movements is the key difference in this situation. If you look at the previous diagram, you can see the eyes are not at the same level. And if you try ocular movements, you will see the eye is not moving in the same way, and the patient would also have diplopia. So that's kind of the general thing with orbital pathology. And there might be some proptosis of the eye, okay? And the intraocular pressure can be normal. However, I put some daughters against visual acuity and intraocular pressure and the pupils, because orbital cellulitis or any other orbital space occupying lesion, if the pressure increases to a certain degree, it can compromise the blood flow to the eye, and then the vision can go down and the pupils may not react normal way, and also the IOP can be elevated. It can be even leading to a situation like Hema explained, where you need xanthotomic antholysis. So there's, as you know, in medicine, there's not hard and fast rules, but in the general early orbital inflammation, you may abnormal ocular movements would be a early feature to detect. Okay, so yes, there's so much more details under each this condition and all the previous ones we discussed, but I think that you can read on your own if you are interested. But the take-home message from this presentation is, if someone presenting with red eye has associated pain, photophobia, reduced vision, high IOP, abnormal corneal fluorescein uptake, or reduced ocular motility or double vision, they need urgent ophthalmic referral. If you look at the previous slide, only in the first two columns, conjunctivitis and subconjunctival hemorrhage, everything was blue, right? No abnormal things are there. So if someone has these features, signs, then they need urgent ophthalmic review. And of course, someone with red eye who's a contact lens user or in the early postoperative stage need to be reviewed with high suspicion, right? And most of these conditions have associated inflammation, so if you use topical steroids, they might subside their symptoms or the redness, but that's a dangerous practice because it can delay the patient presentation and can lead to blindness and medical legal litigation. All right? So, which has happened. Okay, good. So that's my presentation, and I think the floor is open for questions for all three presenters. Is that right, Jen? Yeah. Good. Thank you. Thank you.
Hi, thank you. Thanks for the presentation. My name's Bill. I'm an EM registrar down in Wangaratta. I just wondered if the presenters could comment on the utility of ocular ultrasound for diagnosis of conditions.
So the question was about the use of ocular ultrasound. So it depends on the situation. Sometimes, like if we can't get a view of the back of the eye, then ophthalmic ultrasound is pretty useful because we use it for diagnosis of, say, someone has a vitreous hemorrhage, retinal detachment. In that situation, orbital tumors can be picked up. But and there are different ophthalmic ultrasounds. There are anterior segment ultrasounds and posterior segment imaging systems. So but I think the history and the examination is often very useful in narrowing down the differential diagnosis in a rural setting. Was your question targeted at a specific condition or specific presentation? Or?
In my experience, it's difficult to dilate the pupil in ED.
Yeah.
To dim the lights, and I think that the use of ocular ultrasound has improved my ability to look at the fundus of the eye and differentiate between retinal detachment and transient visual loss, things like that.
Mm-hmm.
I just was curious about, particularly in the incident where you had the patient with the laceration above the orbit, that I think we discussed it going further deeper down, whether that was something that would be easily viewed on ocular ultrasound.
So it depends, because our ultrasound depends on the technician who does it, and if you exert force on the eye when you are doing it, that can cause more damage. I think it's if the media is clear, that means the lens is clear, and you can have a look at the back of the eye. Like fundus examination is much more informative than ultrasound. But if there's no one that is capable of looking at the fundus, then ultrasound is second best option, and of course can help in ruling out a retinal detachment. Yeah, thank you.
Got a comment and a question. The comment first, for those of you like me who don't do much eye stuff, if you do the emergency trauma management course run by Andy Buck out of Darwin, they include lateral canthotomy as one of the procedures that you can practice, and it's actually dead easy. So I reckon I could do one for real. Question that goes along with that, I saw the term up there, lateral canthopexy. What's the difference?
I'll let you answer.
Canthopexy is different to canthotomy cantholysis. Canthopexy is more tightening the lower lid to the lateral orbital rim. So it's like a lateral tarsal strip. I don't know if you've heard of that procedure, but it's an elective procedure that we do when patients have ectropion, so a lax lower lid. So the lower lid is anchored to the periosteum of the lateral orbital rim with a suture. So it's more like a tightening procedure, and it's not an emergency. It's more for ectropions, for involutional lax ectropions.
Thank you all for your presentation. I have a question about the management of a superficial lid laceration. When you're sure that it's superficial, and you talked about suturing with 6/0 sutures, would you ever glue in that situation?
With the eyelid glue, I haven't used glue because I usually suture. I think it would be very uncomfortable with the glue because of the lid blinking every time, and also the you need quite good approximation, which you might not get with glue. So I don't think many people use glue for lids, no.
Hi, I'm Glenn. I've been on many high altitude expeditions to the Himalaya, and I've seen quite a few people at very high altitude get vitreous hemorrhages. Is there any treatment or any prevention or anything that can be done about that?
You mean like when you're
like
trekking
high
up in
altitude vitreous
yeah?
hemorrhages, yeah.
Treatment is possible. So, some vitreous hemorrhages will resolve spontaneously within a few weeks to months if we rule out that there is no nasty cause for it. But, and if not, urgent vitrectomy can be done. So there is a surgical procedure that can clear the hemorrhage and also look for a cause and fix it at the same time. Avoiding vitreous hemorrhage in altitude?
No. Sorry, it's an exciting thing you are doing, but I'm not familiar with how to avoid I'm not aware. Sorry. I wish I could do what you're doing. Sorry. What's the question?
So I've got a bit of a background in altitude medicine. Vitreous hemorrhages and retinal hemorrhages are all very common at altitude, particularly over 3,500 to 4,000 meters. There are quite a number of studies done on them. They tend to be, they cause no problems basically, and once you get back to lower altitudes, the blood gets resorbed and there's no ongoing problems. But they're very commonly found and very commonly seen if you go looking for them, but they're harmless.
Spontaneously resolved, yeah.
Thank you.
Meanwhile, back in Australia, with the lateral canthotomies, etc., in the video you showed it was a very non-red, non-erythematous, non-inflamed eye.
Yes.
that had a little bit of local analgesia. Is there any in the setting of massive inflammation, etc.? What's your role then, both for local analgesia and or subtenons? Are they completely ruled in or out, or and then going on, do they need then closure and suturing at some days afterwards?
The first part of the question, local anesthetic, local infiltration just into the skin, subcutaneous tissue, again needle pointing away from the eye, that is necessary. But I don't think a block might do counter damage because you're increasing pressure around the eye. So no eye blocks, local infiltration will work. Canthotomies and cantholysis, usually if we do them, we do suture them back, 5 days down the track when the insult, the damage is, or the risk is down. But they're known to be left alone and they heal by secondary intention quite well. So both are all right, but if you have access to stitch them, it looks better. The anatomy is better.
Thank you.
Two questions, if I may, please, about the treatment of the cataracts. And obviously questions out of ignorance, but hence I'm asking. With the emulsification, and it's a slight variation, and I think an earlier question in a sense, given that the internal part of the eye is an immune sanctuary, how is the emulsified material ever cleared? Why does it not just leave a constant blur in the patient's vision? And the second question relates to the different procedure, which is the insertion of the artificial lens. Is the patient ever in that eye able to focus?
So in terms of the removal with the fake emulsification, in terms of the removal of the lens material, so essentially the lens is cracked into fragments and removed by this little, it's sort of like a little ultrasound, or sort of like a modified ultrasound tip, I guess, and you gobble up all the lens material. Then you do another procedure after that called INA, so irrigation and aspiration, which is a part of the cataract surgery. So you essentially clean up all the cortical material that is sitting on top of the nucleus, and you clean the bag that holds the lens. So everything should look really sort of nice and pristine and clean afterwards. We know that we can't get rid of every little cell, so after cataract surgery, it's very common to get something called posterior capsular opacification afterwards, which PCO, which essentially is these little cells growing on the inside of the capsule again. But this can be fixed with a very quick laser procedure that takes, a couple of minutes to do. But that is a very, very common side effects or sequelae of cataract surgery. In terms of the lens that's put into the eye after cataract surgery, there is a lot of different options these days in terms of type of lens, in terms of where the lens is put, but also what sort of refractive aim you give the patient. So if you have the monofocal lens, so essentially one lens with a certain strength, you put that into a certain position in the eye based on all the calculations you do of all the eye measurements beforehand, including curvature, astigmatism, lens position in the eye, length of the eye, etc. And most people prefer to have good distance vision. So for most people, we put a lens in that gives someone really good vision looking at the TV or driving or that sort of thing. Some people choose to have monovision, which essentially you have one eye that's good for distance and one eye that's good for close-up work. And then you also have things like multifocal lenses, which has multiple rings that have different refractive, capacities, so that you can essentially see clear at distance, at middle, and close. But with these lenses, there's drawbacks as well, like people complain of halos around lights, the quality of vision is reduced. So, there's pros and cons, but I think if person can ever see clearly again, yes, they can, and it's certainly a lot. If you got a decent cataract, then most people are quite happy having a new lens in. But I do always sort of say to people that just because you have a cataract, it doesn't mean you have to have surgery straight away, because you can have cataracts and have good vision and not have any symptoms or any problems with it. And although the surgery is good, there's always a small, percent of patients that have problems or complications as well. So I wouldn't advertise to do surgery unless the patient themselves felt like they wanted something done.
Thank you.
Hello, I'm Elise, an intern in Darwin. I've just got a simple question. On examination, how do we tell the difference between scleral and conjunctival injection?
Yeah, so conjunctival injection is usually on the more superficial layer, and these blood vessels can be branched with phenylephrine drops in the eye, 2.5% drops in the eye may blanch the blood vessels. And also if you move, after putting topical anesthetic, if you move the conjunctiva with the cotton bud, it will move, the blood vessels will move, but if it's a more deeper blood vessels, then they wouldn't move and they wouldn't be blanched. So that can be useful. Yeah.
Thanks.
Hi, I just wanted to ask a question about ESR and CRP when you're thinking about arteritis. For those of us who don't have regular access to pathology, ESRs have to be processed within 24 hours and quite difficult to get done. How sensitive is CRP in detecting that, or could it be falsely reassuring?
Well, from memory, I think the combination of ESR and CRP is very sensitive in picking up temperature. I think it's something like 95%. The combination of the two. I mean, you can have cases of GCA where both ESR and CRP are negative, but they have a positive biopsy. So I think, again, the history is really important. You know, if you have a very convincing history, you know, of scalp tenderness, weight loss, etc., you know, you would still proceed and treat that patient as if they have, you know, GCA, while you're waiting for the bloods, and you know, you organise for them to have a biopsy, etc. So, yeah, so I think history and examination is sort of would trump even if the bloods were negative.
Only history was so simple.
Yeah.
So thank you, everybody. If we could just thank our 3 Ransco ophthalmologists. That was great. They do have an eye care tonometer here, if anybody wants to have a bit of a play with that. And if anybody wants to watch our slit lamp demonstration in use video, I'm going to run that, and that runs for about 5 minutes. But it's now lunchtime, so feel free to go down to the auditorium for lunch, or have a go at the tonometer, or watch the video. Thank you.